Hi, I'm Koushik Das, and I'm Associate Professor of Medicine at Washington University.
Hi, I'm Sun-Chuan, and I'm an associate professor of medicine at University of California, San Francisco.
We'd like to discuss our upcoming paper in GIE entitled EUS fine needle biopsy of solid pancreatic masses with and without rows for commercial next generation genomics profiling. So, Sun, the genesis of this paper and collaboration, if you remember, was when we were sitting next to each other at DDW, and your partner and our co-author Abdul was presenting on your data on telecytology for EUS of solid pancreatic mass lesions. I was shocked based on that data and the subsequent paper in GIE from 2 years ago that your center was still routinely utilizing rows for EUS of solid masses. Um, so why do you think you still held on to that practice?
Well, I think for me, the biggest thing is that it is still my preference to speak to patients and their families with the diagnosis after the procedure, as opposed to calling them several days later. There's also on occasion, there's also a few clinical factors that may play. Their pancreatic mass might actually be a lymphoma, and maybe you needed flow cytometry, for example. With that said, there has been a lot of needle advancement, certainly, especially since when we were training, and I do think there's some benefits to not using rows as well. The sense I get is that there's a lot of I feel like it's 50-50. Some people use rows and some people just don't. And there's centers that are larger than us and they still use rows. So that's but the short answer would be I just prefer to have a diagnosis up front if I can. But how about you? Because I know that you guys practice very differently from us. What drove you guys to abandon rows?
I mean, I think a lot of the typical things that most centers, you know, many centers have continued to abandon it in the last several years. We were probably earlier than many, but after, sort of some of the papers that have come out recently showing that there was non-inferiority to not using rows, we felt, kind of justified in doing it. Early on, one of my partners and one of our co-authors, Dana Early, had published a paper specifically looking at the question you were raising about, the value from the patient side of receiving a diagnosis at the time. And what was shocking about that study, which is now, probably close to 10 years old, was how few of the patients actually remembered the details of the conversations that were given to them at the time of the procedure because of the sedation and everything else. And that, calling them a couple of days later with a definitive diagnosis didn't necessarily seem to change, their patient experience, as much. I think to procedure time, as well as, some, you know, um, tension that kind of arises, in the room while you're waiting for that definitive diagnosis, were other kind of factors that led us, to kind of move away from Rose more than 5 years ago, for this specific indication, of course. Well, this is exactly why I felt our two institutions provide such a nice natural experiment, taking advantage of a essentially natural practice pattern that's evolved to avoid any selection bias that often affects studies on centers that selectively may utilize rows. I think the last, few years, you really have seen, some centers cling to it and some centers, really, move away from it as time has gone on. There's still, a couple situations where people still feel like rows may have a role, and one of them was in ensuring adequate specimens for NGS testing, which is what we evaluated here in the study. What percentage of cases of pancreatic masses do you think your oncologists are requesting NGS testing for?
Um, it feels like the oncologists are requesting next generation sequencing for almost all of the pancreatic adenocarcinomas that we're diagnosing. I think the rare exception is when you do find a mass where it is immediately surgically resectable. But as you know, that's going to be the minority of the time. So NGS is requested in almost all the cases.
Yeah, as it is in our center as well. So why don't you review for the listeners our study design?
Sure. So we prospectively evaluated cases of EUS FNB that were sent out for commercial NGS testing from both of our centers over the course of 5 years. By definition, these were cases that only had diagnostic cytology or histology, though we had previously published that our accuracy in this area was more than 95%, And I know you guys have similar numbers as well. We included patients that had an EUS FNV performed with a 22 gauge needle. So that means that anyone who had a 25 or 19 gauge needle were excluded to make sure there was no heterogeneity. We also excluded any suspected metastatic non-primary pancreatic mass lesions and any sort of tissue that was acquired without using endoscopic ultrasound. Ultimately, at UCSF, we had 44 patients from our center that fit criteria for the study, and 186 patients from WashU where you did not utilize rows. So 44 patients from our center, we are using rows, and 186 WashU patients where rows was not used.
Yeah, and there were no significant differences in patient characteristics, demographics, stage of tumor, prior chemo, which was pretty uncommon, as most were treatment naive, biopsies 85 or 86%. The vast majority of cases, about 89%, were pancreatic adenocarcinoma, and a similar number of patients in each of our centers had same session ERCP in the setting of concurrent malignant biliary obstruction, about, I think, 32% versus 20%. And the procedure times, I should say, were tabulated only for the EUS portion of the procedures. Adverse events in both centers was extremely uncommon, 1.6% versus 0%. And the adequacy for genetic evaluation was very high and similar between both groups, 85.5% versus 88.6%. And a very similar frequency of patients were found with actionable mutations, 18% versus about 15%.
In a multivariate analysis using rows, sex, AJCC stage, and prior chemotherapy did not predict a significant difference in the rate of adequacy for a commercial genomic analysis. What about the needle types between both our centers?
So both our centers use a mix of Charcot fork tip needles and Acquire Francine needles. I don't believe, however, there was any difference in performance on a per needle basis, right?
Yeah, Francine needles had an 86.6% success rate in obtaining diagnostic tissue for NGS, and fork tip needles had was over 87% for getting material for NGS analysis. This essentially mirrors a recent RCT and propensity analysis that had demonstrated no significant differences in the diagnostic accuracy or the histologic adequacy between these two needle types. I think it's important to mention that in terms of potentially actionable variants, the whole reason that we pursue this kind of testing in this patient population was found in a similar number of patients. It's about 16 to 18% with or without rows.
Yeah, indeed. The field for targeted therapy for pancreatic cancer is rapidly evolving, and the list of gene variants that are considered potentially actionable is, ever growing. Importantly, there have been promising results for KRAS G12C inhibitors, as well as a new pan-RAS inhibitor that's in study for PDAC. While only a minority of patients may harbor low-frequency actionable mutations, the vast majority may harbor these druggable RAS targets. And so I think increasingly we're going to be called upon to do these biopsies for these sorts of analysis. And so it's incumbent on us to, optimize this for patients.
Okay, so with or without rows, we are showing a very similar outcome in terms of accuracy and acquisition of tissue for downstream analysis. So I think what perhaps the audience wants to know is what's the harm in continuing to use rows?
Time, basically. The most striking finding in our paper is that compared with FNB without rows, FNB with rows required more than double the procedure time, a mean of 49.7 minutes with rows and 21.1 minutes without rows. And unsurprisingly, rows ended up resulting in a significantly higher number of median needle passes, 3 versus 4. That means you could do two EUS FNBs without rows of a solid panc mass in the time it took to just do one case with rows. In a busy endoscopic practice, that's a lot of excess procedure time, opportunity costs, and cases that can't be scheduled. Additionally, cost estimates for OR time are about $36 to $62 per minute, which for a health system, really could add up. So I think the Rose cost effectiveness models generally assume a pretty low diagnostic accuracy or reduced needle pass number, though we kind of showed exactly the opposite in this real world experience between two centers.
Indeed, and that really is a huge difference. I will add that there are some limitations to this study. Ultimately, this was not a randomized study, which could introduce potential biases with regards to physician performance, needle passes, clinical assessments of specimen adequacy, and procedural biases. And specifically, we didn't randomize patients to specific fanning, needle pull, or wet suction protocols. The general approach for both centers was to utilize a combination of slow pull and dry suction for fork tip needles and a combination of wet or dry suction for Francine needles. But ultimately, as the centers performed similarly and analysis on a per needle basis was similar, these differences in technique are probably not huge. Additionally, utilizing the natural variance of practice patterns from centers that use rows with every case versus centers that do not routinely utilize rows does eliminate potential selection biases for what you might describe as difficult cases where you would want rows on board. Moreover, the heterogeneity of practice accounts for a more accurate real-world procedural variability at expert centers.
Yeah, I think another interesting issue we did not resolve is like optimal needle size, as we excluded any cases done with a 25 gauge needle, for example.
Right. So there were 38 cases from UCSF that were used with a 25 gauge needle. We did a small subgroup analysis of these cases, and the adequacy was close to 95% for downstream NGS, which wasn't statistically different from using the 22 gauge with or without rows. However, similar to the 22 gauge needle with rows, the 25 gauge needle with rows cases did have a significantly higher procedure times. And 46 minutes versus 21 minutes, as well as number of passes, 4 versus 3. I think an interesting question might be whether we can get away with using 25 gauge needles in certain situations where either we don't want to use a 22 gauge needle or we think that there may be a higher risk or higher technical difficulty.
Yeah, I mean, I think overall the complication rate with the 22 gauge cohort is still exceptionally low, less than 2% in both groups, which is lower than the quoted overall rate of complication in the ASG tech document on the on EUS. So I guess the big question is, are you going to switch away from using rows based on the study?
Well, we haven't abandoned it completely. It's, it's good to know that you can do this so much faster and with similar results. But there are some situations where I still prefer to have the diagnosis immediately afterwards. I think this also comes to you have to look at your practice environment. And I practice where I work at for close to 10 years now. So I can sometimes get a sense of, some cytologists are very capable of giving you a preliminary diagnosis that's accurate right away, and there's other physicians who are a little bit skittish. And for me, I know that if there's someone who is very good at calling things, then perhaps that extra time is worth it. At the same time, if I know that there's someone who is reluctant to give a preliminary diagnosis, then I'm better off just not having Rose in the room.
Yeah.
But how about you? Do you think you would actually use rows in any instances after this study?
No, I mean, I think it confirms our previous hypothesis about, its utilization in this space. I think we'll probably continue to not routinely use it. There are a couple of scenarios, say, for example, in a patient who I really want to be able to place an uncovered metal stent for concurrent biliary obstruction, who has an in situ gallbladder that I'm worried might get obstructed with a covered stent, though I know that's a, debatable topic. I may want an on-site diagnosis, or a person who's presenting with an concurrent gastric outlet obstruction where I want a tissue diagnosis before pursuing an enteral stent or an EUS gastroenterostomy or something of that nature. In those very, very narrow specific situations where knowing right at the moment before committing a patient to irretrievable stent placement of some kind that might, still help me. But outside of those, specific narrow windows, I think we're going to continue with, primarily just placing our FNB specimens into histology and proceeding that way. So anyway, thank you so much for joining us for this author interview. We invite you to read the full findings of our upcoming manuscript in JIE.